And that was before recording, which is good.
Oh yeah, as before. Oh, hey.
We just started recording.
Thank you, Chad.
And there's still a few folks in the waiting room that we're letting in, so I'd recommend just holding for another beat or two before we get started.
Okay.
I think we are good to go, and folks may continue to keep joining.
Okay. Hello, everybody, and welcome back. I have a little bit of I have a little laryngitis, but I don't have to do a lot of talking today, so that's lucky for me. Um, we're at the home stretch. This is the second to final meeting for the Behavioral Health Talent Council, and it's been incredible. And so I want to thank everybody for their dedication and hard work as always. And what we're going to do today is we're going to hear back about we talked about the legislative concept before, and now that actually has a bill number. And so it has gone from a concept to a bill, and that is House Bill 4038. And was presented last week during Ledge Days. Casey Liddell, I know, and it was fantastic. So Casey Liddell, our senior policy advisor, Julie Ibrahim, vice chair of recruitment and retention, Eli Kinsley, vice chair of licensing and credentialing, and Rick Trelevin came and testified to the legislature. They did a fantastic job. It is so they were both in the House and the Senate committee, and it is so meaningful to have folks hear from frontline workers, from people who are out in the community to do this work. The testimony was really powerful. There's a fantastic quote. There are many fantastic quotes, but I thought it was really important for people to see. Julie, can you remind me the N number 30?
35 pages
35 pages. So Julie
of
illuminated for
intake.
people about the intake form and that it is 35 pages and how long it actually takes to get people enrolled in a program. And for all of us that have done that work, it was really powerful just to know that people understand how cumbersome this is. And so it's great to get those stories out there and look to make this process easier. As we advanced into the next phase of the work for this session, I just, it's legislators, as you all work with legislators in your local area, it's important that they hear from you. I know that many of you have said that you're interested in continuing advocacy, and staff will continue to communicate with you on ways that we can do that. So if you have not had a chance yet to respond to staff on wanting to be a part of future efforts, please do so, because we would love that. Also, I'm just going to another reminder is if you as we get closer to looking at the report, I want to make sure we have everybody's bios in with their and so if you've gotten something about your bio, we need to make sure that we cut them down for space. And so just make sure if you've gotten an email about that and you haven't gotten back to us, yes, if you could, that would be lovely. And so with that, it's time to jump into the agenda. The fabulous Amy Baker is going to walk us through the bill. And so Amy, are you ready to take it away?
Yes, I am.
Fantastic.
Chad, do you have the latest version that April sent? Is that the one you're using?
I believe so.
Okay, perfect. So essentially, as you all know, because we heard from different members, there were several work groups that have been meeting over the last year to work on behavioral health workforce. And a lot of the work that's been happening amongst those different legislative groups has been happening simultaneous with the Behavioral Health Town Council. So really, I want to share with you all the work that we did to try to coordinate and align some of our recommendations, and to share like how that's gonna lay out in the final report. So next slide, please.
Oh, let me stop. I'm sorry, Amy. I misintroduced that. This is my apologies, everybody. This is the legislative work group alignment. I was incorrect in that introduction. I'm sorry for that, Amy.
Oh.
But this is, so let me just, so wrong part, but thank you for this.
Do you want me to keep going?
Please do.
Okay, all right, thank you. So probably one of the legislatively required work groups that had the closest alignment with the Talent Council was House Bill 2235. And essentially they were called to study how to increase recruitment and retention with Oregon's behavioral health workforce. They had a lot of similar types of folks who were represented in that work group, and we have individuals on the HB 2235 who also served in the Talent Council, being Shira Marilla and Eric Martin. House Bill 4092 came out of the 2024 legislative session, and that was really focused on administrative burden, along with some other components to that bill. And for the recruitment and retention, there was some pretty significant overlap. Next slide, please. House Bill 4151 was the System of Care Advisory Council, and that work group was really focused on how to increase the workforce serving youth and kids and families. And then lastly, the Alcohol and Drug Policy Commission has also done some work around how to address the workforce crisis, and they put forth recommendations to the Behavioral Health Talent Council. Next slide, please. And so we have the link that you can actually pull and read their final reports if you're so inclined. And I think the important piece here is that you can kind of see that everybody's reports were coming due at the same time. So next slide, please. So some of what the engagement looked like between the various subcommittees is that we had direct participation from HB 2235, which included Shira and also OHA behavioral health workforce folks who participated in HB 2235, who were able to share conversations back and forth. And also we had presentations to the retention and recruitment subcommittee from the HB 2235 and HB 4151. And then there was quite a bit of governor's office outreach to those work groups, including First Lady meeting with some of the different committees, ADPC and 4092, as well as myself. And we're able to kind of hear what they were working on, what was important to them, and what we were also focusing on. Next slide, please. And so out of all of the draft reports, the governor's office team took those, and there were 54 total recommendations from those four entities that I just talked about. And 23 of those legislative work group recommendations were directly in alignment with the BHTC action plans. 19 recommendations were related to workforce, but were not included in a Behavioral Health Talent Council action plan. And the governor's office will review these recommendations for potential implementation. And then lastly, there were 12 work group recommendations that were They were not related to workforce, and those were not included. Next slide, please. And so for the 2235 work group, the with licensing and credentialing subcommittee, expanding strategies to recruit individuals with prior experience. That's in our supporting lived experience action plan. Eliminating licensing delays with transparent standardization, et cetera. That's included in the streamlining action plan. And then there are 3 recommendations that will receive further review through the governor's office. And that includes expanding licensure pathways for out-of-state military and non-traditional applicants. And I'm not going to read off all of these because I don't think anybody wants to listen to me. I don't want to listen to me talk that much. Next slide, please. With recruitment and retention subcommittee, you can see there were quite a few shared recommendations that were included in the Behavioral Health Talent Council action plans, including within supporting workforce. And that's I think there was a lot of kismet between HB 2235 and recruitment and retention around how to really grow our clinical supervision training. And within recruitment and retention, when I say clinical supervision training, I'm also talking about preceptor training and supervision. So we kind of expanded that within our group. There was a lot of alignment around reducing administrative burden, including the required documentation. Julie's example of 25 pages to get somebody into care is I don't even know what to say about that. So there was a lot of agreement there, streamlining regulatory standards, and the centralized credentialing for professional work types to reduce some of the administrative burden on organization, which, as you will note, is in the governor's workforce bill. Culturally responsive workforce, that's the loan repayment and tuition assistance, Latin career pathways, and then compensation. Obviously, it's paying people a livable wage for the work that they do. Next slide, please. Uh, 4092, this is the admin burden. Agreement around updating the OAR 309s for those of you who are not rule nerds. The OAR 309s are basically the rules that require documentation standards around what somebody needs to have in order to get into treatment. And so that specifically, we hope will hopefully address the 25 pages that Julie talked about in her testimony. Additional recommendations, one rulemaking webpage for all of OHA. Sometimes it's hard, the rules are like in statute and OARs, and sometimes it's hard to track them all down and maintain compliance. Rulemaking transparency, around creating space so that there's an opportunity for a lot of community input before rules are finalized. And I can say that the governor has expressed her expectation for the various departments to do exactly this, to have rulemaking transparency. And then and this is like more specifically to kid serving providers, but to align the rulemaking process for OHA and ODHS. Right now, if you are a kids residential provider, you have rules that lie in both departments, and sometimes they're duplicative and conflicting. So next slide, please. 4051, This is focused on youth. Central space for career tracks, that the career tracks, I don't want to call it like it's not a hub, a web page, whatever you want to call it, where people can go and figure out like where they see themselves in the behavioral health profession. That came up, I think, in probably every subcommittee, and that also got called out by HB 4151. And then additional recommendations, new credential for licensed bachelor's level youth and family behavioral health provider. I believe there's a Balmer bill that's sponsoring this legislative session. Expanding behavioral health career and technical education CTE programs. And then pay parity for youth providers, developing a rate formula that utilizes current wage and expense data. Next slide, please. And then lastly, ADPC also had a set of recommendations. And ADPC is the Alcohol Drug Prevention Council, and their recommendations were around ensuring that folks who are being trained to provide mental health services are also getting training around how to address substance use, so that our professional types don't continue to be so distinct and not integrated. Career and technical education for high school youth, so bring folks into the workforce early. And peer recovery support services guidance. We had a lot of conversation about that in the recruitment and retention. And then creating a co-occurring certification or endorsement for providers who are doing both SUD and mental health. Next slide, please. And that was a lot. And I'm sorry for talking at you, but does anybody have any questions?
I just had a technical question on the new bill 4038. That was LC 216, right?
Correct.
Okay, thanks.
So can I jump? I'm going to jump in here since I didn't. I want to more properly introduce that topic because I don't feel like I have it. So let me rewind. I do want to say, some of this I remember when we were in the beginning of this, and there were these other work groups that had happened that people had been a part of, and we had said these aren't competing. We're not competing with these groups. We're trying to bring all of this information together and put forward the best recommendations. And so I want to shout out the incredible work of staff. Of pulling together these various task force and then crosswalking these things. Like, this is an incredible amount of work. No one does. I mean, there's no one actually assigned to do this. It is people taking initiative to make it happen. And that is what people have done here. And it also says that every time you've worked on those, if you have been on another task force, and this is another opportunity, your work is being uplifted. You were on this task force and now it's being uplifted through the BHTC, and it shows that all of this is funneling together. And I think I've said before, like, when we're all getting the same answer, we're not competing. We know that means it's the right answer. And so we should hear it repeated a few times. And so I just want to say that it's really meaningful, and I'm really grateful to the staff of pulling this all together. We'll get you the bill number. I jumped ahead a little bit on that. But so that is kind of what this work is. And so sorry I didn't properly introduce that, and I wanted to go back. Go ahead, Robin.
Thanks. I have just a quick question. Amy, you mentioned that there were a number of recommendations from another chunk of groups, or I think like 19 recommendations that weren't in the Behavioral Talent Council action plans, and that they were going to be addressed. Does that all get addressed in the same bill, or are those ones happening somewhere else?
So,
just curious.
Yeah, no, thanks for that question. I probably could have clarified that better. And so the bill has like 4 components to it. The final Behavioral Health Talent Council report will have many, many more than that. And so like we want to make sure that we give due diligence to all of those recommendations. And so those are going to get reviewed, and the governor's office will determine whether or not those end up going in the final report, and then decide about prioritizing which recommendations. So it's not, and they may end up in another bill, but they won't be in the governor's bill per se.
Got it. Thanks for clarifying.
And if I can jump in and add one thing for Slady, for folks who have the draft report in front of you, it's Appendix F that outlines all of the other work group recommendations that Amy just walked through, and you'll see it notes where that recommendation lives in an action plan. And if it doesn't, then the governor, when she's reviewing your all's report, will see the legislative work group recommendations, where they are in a plan. And which ones aren't in a plan as she reviews, to Amy's point. So it's sort of all encapsulated as part of the process. And as you all know, a lot of these reports were due December 15th. And so although the alignment work that staff did was incredible, this is a really comprehensive capturing of everything, even if it wasn't perfectly aligned during that process. So that's all I would add.
Thank you, Taylor. Liz?
I just wanted to ask, I was reading in the appendix for the first responder stuff for crisis workers, and it said that there is going to need to be more investigation if moving forward on that. Where are we at with that? Are we going to continue to investigate?
Ooh, okay. This is getting, oh, good. Here's what, let me jump in. We're gonna walk through the report. So what we're gonna do next is, if any questions about any questions about the work group piece. And then Casey's gonna do a report back from our, from meeting with Oregon sovereign nations and then we're gonna go walk through the actual report. So that would be the perfect time to bring that up. Okay. Any other questions about the legislative work group alignment? Okay. So next we're gonna move out and we're gonna move into the tribal coordination report out. And in the second year of the governor's term, she and as I accompanied her when we visited all of our tribal nations, we had the opportunity to visit our tribal clinics, which in many ways are leading the way in some really great behavioral health work. And so Casey has done a great job of working with folks. We had a meeting with the governor's office, Julie Johnson, who's the director of OHA and the Office of Tribal Affairs, to do some coordination around the council's work. And so 8 of the 9 tribes were able to attend. And then we also had in person, and then we were also able to have a meeting with NARA in Portland, and Casey will present on the feedback of those meetings.
Thank you very much, First Lady, and thank you very much, Chad, for already having my presentation pulled up. As the First Lady said, we've been doing a lot of work to make sure that the work of this council is coordinated with work that is already happening in Oregon's 9 sovereign tribes in their provision of behavioral health services. We've had some really fantastic conversations, and we had a great meeting a couple of weeks ago where all of the tribes were invited to talk to us. So next slide, Chad. So I just wanted to give this background for people who aren't necessarily aware of all of the sovereign tribes and federally recognized tribes here in Oregon. So there are 9 federally recognized tribes in Oregon: the Burns Paiute tribe, the Confederated Tribes of Coos, Lower Umpqua, and Siuslaw Indians, the Confederated Tribes of Grand Ronde, the Confederated Tribes of Siletz Indians, the Confederated Tribes of the Umatilla Indian Reservation, the Confederated Tribes of Warm Springs, the Cow Creek Band of Umpqua Tribe of Indians, the Coquille Indian Tribe, and the Klamath Tribes. As you can see here, they are geographically spread all over the state, and a number of them are actually serve as the primary service provider in their region due to the difficulty of accessing healthcare in some of these rural regions. So they do not just serve tribal members, they actually serve people throughout the region. Next slide, please. So our relationship with the 9 tribes in Oregon is a unique relationship because they are sovereign governments. So we have a government to government relationship between the state government and the governments of the tribes. That means that we have processes to make sure that we are respecting that relationship. And so we began the process of sort of collaborating with them on this by sending letters to the all 9 tribes. This is often referred to as a Dear Tribal Leader letter, letting them know about the work of the Behavioral Health Talent Council, providing them with the talent assessment and a rundown of some of the work that we had done up to that point, and then requesting that they have someone designated to attend a meeting with tribal or with governor's office staff and the First Lady in her role as the chair of the Talent Council to have a conversation about the work that the Talent Council has done, some of the work that the tribes have already done that really aligns well with the Talent Council, and to get feedback and recommendations from tribal representatives. That meeting took place on January 7th. We had 11 representatives from 8 of Oregon's 9 federally recognized tribes at that meeting, including 4 elected tribal officials. We coordinated that meeting with existing cluster meetings, what are called cluster meetings, that the OHA puts together to get feedback from the tribes and collaborate with them to try to make it as convenient as possible for people who were already coming into Portland for that meeting. We also had a number of people who joined us remotely, but as you can see, there are some people who traveled significant distance to be able to be involved in this conversation, and we really appreciate them making that time for us and making that space for us to have this conversation. Next slide, please, Chad. So the talent assessment itself identified specifically some gaps and recommendations regarding tribal providers. Particularly, there is an underrepresentation of Latina, American Indian, Alaska Native, Black, and Pacific Islander healthcare professionals, and an overrepresentation of white and Asian individuals, particularly in higher paying roles. So there's a significant wage gap across the demographics. There's a lack of appropriate training in schools and on the job for cultural responsivity, specifically for American Indian, Alaska Native, Latina, and rural communities. That is something that we heard from our culturally specific provider conversations, and something that was reiterated in these tribal conversations. Practitioners from the American Indian, Alaska Native community are underrepresented across all behavioral health roles, but particularly in medical specialties. And there is a critical shortage of mental health providers in Oregon's rural and remote counties, which, as I noted, includes a number of the areas where the tribes are located, and in some cases are sort of the primary healthcare providers. The talent assessment recommended offering region-specific behavioral health career roadmaps to encourage the grow your own approach for tribal, rural, and remote communities, subsidizing housing, relocation, and childcare costs, particularly in rural areas with underserved communities, and increasing access to in-person and virtual behavioral health resources in rural areas with culturally competent survivors. So you've already definitely had conversations about these recommendations in both our subcommittees and here in the main group. And I just wanted to sort of show that some of those, the work that you have already been doing is already in alignment with these recommendations that were made by the Talent Council. Next slide, Chad. So another body of work that we reviewed going into this meeting was the Oregon Tribal Health Strategic Plan. This is a plan that was created by the 9 tribes in partnership with the Oregon Health Authority. This is a 5-year plan to improve health outcomes for tribal communities across Oregon. This is another place where we sort of looked to identify gaps that the Talent Council could potentially be working on through our action plans and recommendations. One of the challenges that was identified by the strategic health plan was workforce and training. They noted that the workforce is defined by non-native culture with inadequate training, care, and support. And as their first strategic pathway in that strategic plan, they identified nurturing a healthy workforce. and stated this pathway seeks to support the existing tribal health workforce and promote its continued growth. This will be done by supporting accreditation programs, enhancing provider incentives for retention, continuing to offer tribal-specific cohorts across the health field, and supporting mentorship opportunities and cross-training activities to connect one another in this work. Next slide, please, Chad. So the strategic health plan also notes a number of concrete action steps that could be taken in order to meet these goals. And you will notice that there is a lot of, again, alignment between these action steps and some of the recommendations and action plans that the Talent Council has been working on. In the next few slides, we will actually show just how aligned those things are. But as you can see, there are recommendations to define healthcare positions and categories of departments, create a comprehensive job description repository, implement enhanced provider retention incentives, deliver tribal-specific and trauma-informed care and historical trauma training program, implement workforce wellness and self-care initiatives, establish trauma-informed mentorship programs, support training programs specifically for working in tribal communities, and map tribal-specific credentialing systems for behavioral health and public health workers. Next slide, please, Chad. So we looked through all of the plans that have come out of the Behavioral Health Talent Council and aligned recommendations already existing in this work with the recommendations in the Oregon Tribal Health Strategic Plan. So I won't read through all of these since I have already read the tribal side of them and you have already reviewed all of the action plans as they've come through the committee. But I just wanted to show the work that has gone into showing that there has been a lot of alignment between these two sort of visions of how we can improve our support of our behavioral healthcare workforce. And you can see, if you look at these materials later, you can see that we've sort of called out specific plans where we see each of these areas living. Next slide, please, Chad. This is the next few recommendations and their alignment with the strategic plan. Next slide, Chad. And this is the last set of recommendations. So you can see there's really alignment with every single one of the strategic recommendations from the tribal health plan. And next slide, please, Chad. We wanted to highlight some of the feedback that we had in that conversation with the tribal representatives who came out to join us, which again, a lot of which really lines up with what we have been hearing from other behavioral health providers as well, but I think really highlights some of the specific challenges that are seen in these settings that they are working in. So one that I think really was a focus was the difficulty of creating truly co-occurring services. There's sort of our system has not caught up with what everyone pretty much agrees is best practice at this point. And I think in a lot of ways, from everything we heard, a lot of the tribal clinics have actually are ahead of what's happening in a lot of other places in terms of treating the whole person, in terms of aligning not just mental health and substance use treatment, but aligning all of that with physical health treatment, dental treatment, basically having a one-stop shop for wellness, and acknowledging the fact that each of these areas of wellness has an effect on the others. But they did note that the same problems that we have heard from other providers who are trying to provide co-occurring services, including challenges with licensing, billing, and reporting requirements, are impacting them as well. And particularly for some of them that are smaller providers trying to provide these services, it leads to some specific difficulties, including the amount of work they have to go through to get some of their staff approved to be able to work in the area. There was an emphasis on understanding intergenerational trauma and its effects on communities. That's something I think where it is very difficult, particularly when they are bringing in behavioral health workers from outside of the tribe to work within their system. It's really important for them to understand all of the context of the work that they are doing. And that's something where I think the training is currently lacking. People are not necessarily coming in with that background and that understanding of how to work with a community that has been traumatized and has sort of been had all of this terrible history that has occurred, and how to help people work through that. The importance of encouraging young people to see careers in behavioral health is a real option. They really noted that that was something that is not necessarily something that they see youth and adolescents thinking that they will do in the future, not necessarily because they don't have regard for it, but because they don't even know that it's a potential career that they could go into. There was some discussion of non-traditional hours for helping to recruit behavioral health professionals, particularly in rural communities when it can be difficult to get someone who can come out and work full time or who doesn't have sort of like other obligations that they have to be able to meet. That means that having potentially evening hours or potentially working different days or things like that could make the job feasible for them when otherwise it wouldn't be. So flexibility around sort of the way the workday is organized. And then increasing access to clinical supervision, particularly for smaller providers. That came up and has come up in a number of our recent conversations with workers as really something that has been a barrier for people to be able to get fully licensed and sort of meet their professional goals, is not being able to find people who can give them their supervision hours. And so this is somewhere actually where the concept from LC 216 of allowing that cross-license supervision was really welcome in that conversation, because they noted that that is a barrier for them, is sometimes having their supervisor is a licensed professional counselor. They have a tribal member who has gone off to get their social work degree and come back and wants to come back and work within the tribe, and they can't because they don't have an LCSW who can supervise that person. So that's something that it was good to hear that we are in alignment with them in terms of what they need. And I think we want to continue to make sure that we're supporting that. So that is the end of my presentation. I will just say, I think from my perspective and the perspective of the whole governor's office, this was an incredible opportunity to get to do this collaboration. It was a really good conversation. It was a really sort of, like I said, profound that we were welcomed into their space and welcomed into their conversations about this. And we're really looking forward to continuing to work with them as we look at implementation of the Talent Council's recommendations.
Fantastic. I was gonna, yep, moving into it. Does anyone have any questions? Clarissa?
Thank you. Yeah, Casey, that was amazing. Just wondering from the psychiatry provider perspective, I don't know any PMHMPs who are down here on our Klamath tribe, or helping our Klamath tribes or any of the tribes down here in Southern Oregon. So, we talk about this behavioral health umbrella and that psychiatry is in that umbrella, but we are trained very differently. As far as I understand, we can't get all of our hours from MDs. We have to get some from psychiatric nurse practitioners. How is that even possible? I give culturally, as good as I can care to my American Indian patients. And I would love to have been trained more on that, because we do have Native populations down here who are seeking care from an FQHC. But like, where can we provide? I'm wondering if you got any insight about that in terms of psychiatry, because that's going to be like even harder, I think, than when we talk about those clinical hours. Because clinical supervision and clinical hours are, we're trying to kind of say clinical hours to represent all of us, because it's not clinical supervision for us, but those hours that we might get from a preceptor or, somebody who has cultural experience, is from the culture, just so highly valuable for medical providers. And yet I don't even know where I would start, to be honest. I was actually going to email Eli with some questions the other day.
Yeah, and I mean, I will answer that as best I can, not being the expert. But I do think, I mean, I think we heard a little bit. There was one tribe, I don't remember who exactly it was, who said that they did have like a homegrown psychiatrist who was someone who came from the tribe, went through all of the process that they needed to in order to be able to work as a psychiatrist, and came back to the tribe and was doing that work there. I think that that's really difficult in some of these settings because they don't have the educational institutions there to be able to do sort of that work right there. And so a lot of them end up having to leave, having to go through all of the expense of moving and settling in a new place and getting their degree and getting all of their hours and everything. And I think that presents a significant difficulty. And I mean, as we see in the numbers in the talent assessment, there is already a significant deficit in terms of American Indian representation in those fields, and particularly towards sort of those higher paying. And that comes from a lot of historical inequity and a lot of historical barriers that are still there in terms of it being very difficult to move through that system.
And
So
let me just highlight one thing I just said. Psychiatrists are MDs. We cannot get all of our hours from MDs.
yeah,
So here in Oregon, if I understand correctly, PMHMPs are doing the majority of prescribing. But yet even the opportunity that you just highlighted wouldn't have worked for many of my hours as a Psych NP. I would love to give culturally appropriate care. I mean, I hope that, we're understanding the limitations for the psychiatry side of things too, that like that I've heard such a great idea about that, being able to train with multiple people of different licensure, as long as it's within like your pathway. And if there's any wiggle room for that with Psych NPs and our credentialing and our training, so that that psychiatry provider who's American Indian, maybe they can train us too, or we can do some hours there, but we have a lot of limitations. So I just want to highlight, I want to go back to that point that like we can't even utilize that option,
yeah, and I think that's a really good flag for us to do follow up on and potentially incorporate into our implementation plans. Because yeah, that's something where it did not come up in that conversation, and it's because I think there are plenty more conversations to be had where we can identify these specific gaps and help. But I do think some of the work around education and training, both in terms of incorporating these things into earlier curriculums, but also then figuring out how do we give the current workforce the resources to be able to be getting this culturally specific training. Rachel?
Eli, I actually think if it's okay, you should go first, given the comment. And I was going to actually say that before you even put your hand up. I was going to say Eli probably has some things to add before I add some context. So please go before me.
Well, I guess the thing that came to mind is as Casey was providing his presentation, and I don't know why I didn't think about this when we were in our work group, but one of the restrictions of supervision is one of the requirements is you have to meet in person at least on a monthly basis. So that puts an added burden on somebody who maybe represent that particular demographic or cultural identity to then go out to that very rural community to find a way to go do that. So that I mean, I'm almost wondering if there could be a waiver if you are, identified as a culturally specific type of supervisory provider. I do appreciate though going out and really braiding together the various themes and the impacts that are happening to the community members. I know that for some tribal members, it's very difficult to even think that they could get into this field because there's this perception that you're adopting the white wave model of treating your people, particularly if you have a more traditionalist view. And the way I've kind of helped explain that to folks is it's not adopting it fully, but it's integrating already what you know that's specific to your people, right? And there's ways of doing that. And I think sometimes that can be very daunting because they're like, oh, I don't want to give up who I am to maybe treat from a very westernized model, because those are the dominant models, right? All of the very specific westernized models that you have to learn as a part of your educational track. So for some, it's a little difficult. That sometimes that becomes like a cognitive, or like a barrier to them in their mind, I think, so to speak. But I think having tribes have more access to people who are understanding and navigating that, even, providing them support around, like, well, who can you consult in order to build these within your own community as well. And so I'm so appreciative that you went around to the various tribes and really had that discussion with them and offered all that support.
Okay, I'll jump in now. So a couple of things, and I want to kind of do what I've been doing and talk about the situation that you elevated and some of the ideas and how we're doing it in nursing, because they're models that have been done. And then maybe give a little context on Clarissa, and I'll do it, statements, and I'll do it as fast as I can. But before, there's a book I read about 25 years ago called The Scalpel and the Silver Bear. Bear. I know my accent comes out when I speak in public, but it is about a Navajo woman surgeon trained in Western medicine, and it's definitely a book that impacted me. And if you're interested in what Eli was talking about, I recommend it. So talking about being able to add flexibility for nights and weekends, we had to do that in nursing, and it's working. I've had presentations to our board when I found out about where it was working and how rural communities were partnering, the college, the university, and the hospital system. And these are places where there's nowhere else. So they really have to partner, where the Portland metro area is just real messy, and they're wanting us to regulate it, and instead we're having conversations. But what they're doing is, I have this student but can only do nights and weekends. Can you find someone that's going to help on nights and weekends? And they are really making it happen. So there is a model for that at our community colleges when it comes to nursing and some of our systems. So hopefully, if anybody is interested in speaking about that in the behavioral health space, the nurses will always be willing to talk about that. The other thing was about pay. How do you take time off and do that? So the models out there, and of course, it can't be a psychiatrist probably, but other behavioral health techs, our CNA model is that they're getting paid to take the program, right? Where they're going to work. And I think that can also happen. So those are the creative things that have been done in nursing. And then as far as what you mentioned, Eli, about the flexibility around meeting in person. So when we just updated our Division 20 rules, and I'm saying this because so much can be done in rules, I don't know if this is in Todd's rules or not, we allowed a lot of flexibilities in our rules, up to 50% simulation lab, and all of these different ways to say, especially in our rural communities, we need to make sure there's flexibility. And then it's put on the programs, right? Like, we're here, I don't want us to talk about what we put in law on this stuff, but it can be done in rules and across programs. And then lastly, the complexity of what I think Clarissa was saying is, actually, I don't know if I need to get into it anymore. I feel like you were able to do it. I just think what I've learned is, in the behavioral health space, we're not necessarily thinking about our psychiatrists and our psych NPs. We think of them in the medical space. And so therefore, the people that we're saying provide this care and we need may not be getting integrated, or something is happening in interpretation and implementation that impacts that. And so how do we blend that? And then the last thing, actually, I love that you visited all the tribes. And one of the things I love that they're doing is they're all on Epic. So their behavioral health and their primary care are all on Epic, and it's interoperable. I'll stop there. Thank you.
Thank you. I just want to, has the discussion about virtual supervision come up in any of our subcommittees? Because full disclosure, I was doing that process when it was during the pandemic, and so it was virtual. And it's obvious maybe that's since changed. And the ability to do virtual supervision, I know, can be huge around transportation, all of that. So I'm just wondering, did that come up? It's an interesting, it's okay, Eli, that he's like, I'm just thinking about this now. Sometimes this is how this happens. This is why we have these meetings, and it's just because that's a really interesting point. I know that at one point was how it was. It would be interesting also to compare the differences between you when you could be supervised clinically virtually as opposed to having in person, because I would suspect we had more options. So, uh, did it come up? And then, maybe we can, it is an important, that's an important flag.
I can jump in if you want. I don't recall it coming up, but if it did, I think the understanding would be really around the flexibilities and whatever rules are written for education, right? And we oversee, oh, sorry, I didn't see your hand, Eli, but we at the board do oversee nursing education, so could do those flexibilities. I don't know if it's done that way in regulation in that space, but we were able to add all the flexibilities. Now, of course, the school isn't going to want all of your clinical hours to be virtual, right? You need to have all the different rotations. But there's no stated rule that once a month something has to happen in our space.
That makes it, yeah. And we're talking specifically about not
Mhm.
clinical hours, but supervision hours. So this is just with your supervisor.
Yeah. And what I was referring to was remember my experience, because one of the clinical supervisors I had at the time, he was moving and he moved to another state. He had multiple licenses in multiple states, and he was going to move to another state. And he's like, "Oh, I'm going to have to travel back to Oregon because I have to meet with you at least once a month in person." And I go, "Really?" I go, "Well, we've been doing mostly everything virtual." And so I don't know. It seemed like that was a specific rule for the social work licensure. I'm not sure about the LPCs and so forth. And maybe Summer has some more context on that.
Yeah, Summer.
Yeah, thank you. I was just going to jump in and say it's really inconsistent, and there's spots where, there are places where it's been modernized to say things like real-time audio visual, which is really helpful. And then for, I don't remember if it's the 309 019s or 018s, but one of the little subsections, this little teeny part says that for mental health interns, you have to have, the supervisor has to be physically present. And I was like, what does that even mean? And so I was sending it to the CCOs, and I was like, we have like 9 locations all around. Are you saying literally I have to have a clinical supervisor in every physical building at the same time? Because that isn't possible. And I mean, thankfully, we kind of maybe loosely defined it. But the way the rule is written, technically, it's a huge barrier. Just in that one little spot. In other places, it's updated and it says real-time audio visual, and that makes much more sense.
Todd.
Yeah, I was checking. I do not want to speak on the social work board rules.
Sure.
But for our boards, and I wasn't here during the pandemic, but I don't think we reversed anything from the pandemic. We just specified that the supervision needs to be in person in a professional setting, i.e. don't go to a coffee shop where you can't maintain privacy, or through the use of what the actual language we use through live, synchronous, confidential electronic communications. Basically, it's setting out Zoom, FaceTime, anything like that you can do. Other than that, we have some restrictions, like you can't load up all of your supervision hours in one meeting. It needs to be spread out through. We want to change the wording on this. For right now, you can get 50% of your hours through group supervision. But we want to change the wording, because right now an unintended consequence could be you could effectively restrict somebody who's still got the required hours of in one-on-one. But if they get more, if they choose to do more group supervision, then it could kind of impact them and move that. But so yeah, so I think it looks like the rules that we have around are mainly worried about, let's get quality supervision. Let's spread it out one-on-one, 50%, but they can do live electronic supervision.
Okay. Oh,
I just want to ask one quick question. Is that in statute or rule, Eli, what you mentioned? Because when we changed the PAs, I had worked on this bill, it used to be very structured that they had to meet once a month, specifically once a month to review this many charts with their collaborating physician. And we removed that from statute for flexibility. So I didn't know if this was statute or just rule, thinking about it.
Yeah, honestly, I'm not 100% sure. I just remember my supervisor specifically telling me that because he was having to travel at least once a month. So I mean, I could definitely look it up, but I don't know if it's statute or just rule. I'm assuming it's probably just rule. He was more familiar with the rules and really was really particular about that. Yeah.
so here's what I think we should do. This has been a really helpful discussion. I'm gonna look at Taylor. Let's check into this and come and bring it back. And see if we can find a light. Let's find out what's happening, see what, and then then we can, and then we can figure out alignment. But just let's first clarify kind of what all of them are saying, because I do think this could be, I think there might have been a discovered opportunity here, but I don't want to try to make it up in the moment without all the information. But I really appreciate this discussion because I think and I just want to remind people, supervision continues to come up as a huge part of this work. And so if there's more opportunities, this is in alignment with what we've been working on. But so let's get some more information and come back. This has been really helpful. And then it's time to take a break, and then we're going to talk about the report. So do you want to do 50, do you want to do 10 minutes? Let's do 10 minutes. I got to figure out the math in my head. What is that? 303? 302? 303. Okay, we're going to come back at 303, get him some stretches and some water because we're going to talk about the report. Woohoo! I'm sorry that there was a little bit of a mismatch between what the agenda said and what I said around coming back. So people did, but I'm not going to leave people behind. Just grab a drink of water. Do it. I'm just, we're ready. When we're ready, we're ready. I want people's full attention because, and we'll go through this together.
And I apologize, I had to miss the first part of the meeting, and we had some things happening here locally, and so I'm here. Thank you.
Well, I want to say you missed us talking about your great advocacy. And we were very happy to have you, and you did a wonderful job.
It was fun. And of course, Eli and Julie sort of did all the legwork, and I could just do emphasis afterwards. So they did all the hard work.
Well, you represent an important perspective from rural Oregon and also from your long service in this field.
I loved it, Rick, when you said, use your common sense, people.
And I was like, he said it.
Great.
It really was a lot of fun, and it really, I just can't underscore enough. I think it really does matter to have providers and educators and people from their district have these conversations. It makes a difference. You're trusted. You're serving their constituents. You have a shared mission. You live in the same places. Your neighbors. It matters. And you could see it in the committee. I mean, and as they said, we'll get people the recording, but it was really really great. And there was an unexpected story about how great it was, and so that's how you know that you've done good work.
Well,
And I think, oh, go ahead.
I liked it that between some of the most conservative members of the legislature and the most liberal members of the legislature were on the same committee, and they were both like, yeah, makes sense. Let's just do this. Right. So you know you're on a good thing when you have that going on.
Thank you for that point, because I think that's also really important. This is not a partisan issue. And it's so important to have nonpartisan providers and educators talking about this to remind everyone. And so that is also a key factor, that this touches all of our lives, regardless of party. And right now, more than ever, we need to be reminded how we are more alike than we are different. So with that, looks like we might be, are we ready, Taylor, you think? Okay. And at this point, this is Taylor and our incredible vice chairs are going to take us through, and we're going to look over the report.
Thank you, First Lady. Thank you, everyone. I am going to share screen here on a PowerPoint presentation to walk through the full, an overview of the full report. So you all should have received that in email from Chad a couple of days ago. So if you want to have the full report open at the same time as I walk through the PowerPoint, you are more than welcome. As a friendly reminder, folks have until Friday tomorrow if you want to just send us detailed written feedback, but welcome a lot of discussion and feedback today as well. So I'll walk through the overall structure as well as wanting to make sure we're incorporating the feedback that the full council has provided throughout your process. I will give you kind of a heads up on some sections that are still in progress to be added based on some incredible vice chair feedback. And then we will close with sort of next steps and what we want to remind you that we would love from you before the report is finalized. So with that, I think I'm sharing screen, but not the full presentation mode. So Chad, let me do this today, and it might have been my mistake. But can you see the split screen or the full screen?
Split screen.
Okay, one moment. How about now? Great.
Full
Can
screen.
you see the full screen? Wonderful. Okay. Yep. Thank you all so much. So since I have mic privileges, I also just want to take a moment to again really thank vice chairs and the First Lady, the chair, all of you for the incredible work that went into this report, and to really do a shout out to Chad and Hannah, who have been working really hard on the draft that you've received, as well as all staff and team. So again, we'll go over the report itself. You'll see throughout the presentation that there are nuggets of your all's feedback highlighted. So as you were providing feedback when action plans were coming forward, Staff was working with vice chairs to look at that feedback, make sure it was reflected in the action plans. And we pulled out some areas where we are going to recommend to you all that we add it to the final report to make sure that all of your feedback is fully incorporated. We will also talk about the additional plan changes coming for the second version, which you'll see next Thursday for adoption and sending to the governor. And we can have feedback and discussion throughout as well as at the end. So not sharing a screen and walking through the entire report, we're going to focus really on the subcommittee sections, but just to review for folks the core elements of the introduction. So there will be a letter from the chair and the vice chairs to the governor and behavioral health stakeholders, because the audience of this report is, of course, the governor, who will review and make decisions about next steps and actions from the executive branch. But it's really also to a broader group of stakeholders who care about this work, know that it's very important, and may take up some of the recommendations in this report themselves. So we have the executive summary. We have an overview of the Behavioral Health Talent Council members, all of you. So friendly shout out and reminder to please check this section in particular and make sure that we have accurately captured your credentials, your names, your employer and positions. Then we have a section on the Talent Council staff to recognize their hard work. We have a section about understanding the crisis to really set the stage. Next, there is a section about the landscape, and this section's purpose is really to outline all of the various efforts that existed, assessments and work groups prior to this council coming in to really pull it all together. So this section really outlines the legislative work groups, the number of reports that existed about specific aspects of the crisis, to really help make the point that the work of this council is an umbrella effort to pull all this together to have a comprehensive action plan for the state of Oregon. And then next, there's a review of the core findings of the behavioral health talent assessment, which of course was the grounding for the report itself. And we can talk about this a bit more later, but Liz, to your question earlier, that's a really great prompt. As you all know, through your subcommittee processes, the subcommittee action plans were really focused on the 66 recommendations that came from the talent assessment and strategies to move those recommendations forward. And then throughout the council's process, the governor's office, first lady, council members did engagement with that you have heard about, culturally specific providers and organizations, with Oregon's tribes, with frontline workers. And during that process, feedback would get brought to subcommittees to incorporate into the action plans connected to the talent assessment. And where there may have been recommendations that weren't connected or had the full amount of time to be really fleshed out for feasibility, they're still included in the report, even if they're not in an action plan. So just to summarize, like, the governor is going to see the whole landscape of what you all have done in terms of your action plans, as well as the full landscape of the feedback that the council received. So that will all go to her for consideration. So if something isn't specifically in an action plan, it doesn't mean that it won't be considered by the governor's office. So I just want to name that. Any questions about that before I move on to the subcommittee portions? Fantastic. And I'll try and talk as little as possible so you all have as much time to discuss as you'd like. So starting with recruitment and retention, Julie, I will turn it over to you to give a recap of your subcommittee's work before we jump into council feedback.
Okay, and Taylor, are there slides on problem and progress, or am I?
Oh, sorry, just so the slide on the plans and the unique strategies. So whatever words you would want to add from your subcommittee in terms of your all's focus, but it doesn't need to, yeah, whatever you'd want to say before we jump in.
Okay, we had 5 focus areas. Administrate, and you've seen this presentation before in multiple meetings, but we had one on administrative burden that had 4 strategies, and some of that we gave testimony on last week. We had 4 strategies under workforce supports, 9 strategies under culturally responsive workforce incentives and cost of education, 5 strategies under compensation, and I think we had 3 strategies under incentives for underserved communities. Next slide.
Thank you, Julie. And for the recruitment and retention subcommittee, jumping into sort of council feedback. So again, staff were noting all the feedback that was provided during the meetings to make sure it was included in an action plan. And there were a few pieces that I recommend to you all for your discussion to add to the report. So not currently in the report, but did come up in discussion that we would love to add. So the three are that the governor's office should explore opportunities to address challenges with electronic health records, including aligning medical and behavioral health systems more efficiently to improve care and reduce burden or workforce that has to search through records to understand their full medical and behavioral health picture. So that was one that came up during discussions on recruitment and retention plans. There was also a recommendation that the governor's office should reach out to the family of Haley Rogers about naming or dedicating a future bill or program in her honor. The last was that the governor's office should work with the legislature to ensure that the legislative concept that's currently under discussion that's requiring behavioral health providers to adopt safety plans aligns with the best practices that are outlined in the action plan from the recruitment and retention subcommittee, which was also informed by workforce feedback. So these were three pieces of feedback that you all had that I wanted to just check for alignment and see if folks have any concerns about incorporating these into the draft you'll see next week. Okay.
Can I say one more thing, Taylor, before you go on to the
Please.
next
Please, yeah.
group? I just want to thank my subcommittee. They were very engaged. You all were very engaged. We had a lot of great expertise and points of view. And I was really impressed that the attendance was great all the way through the end. I mean, there was just a super amount of engagement, and many, many thanks to the governor's team and the OHA team for support on this project. Outstanding work, really.
Thank you, Julie. And for folks who potentially haven't had a chance to look through the full report, please know that as you look through it, you're always free to email us through tomorrow to give your feedback. So if you don't have feedback in this moment, that is absolutely okay. And we'll make sure to send you an email so you know where to send your feedback. Okay, so then next there was one other piece of feedback that came up during the recruitment and retention action plan discussions. And it was specifically about a child care tax credit. As one of the recruitment and retention subcommittee recommendations, there was some discussion of the council around broadening the exploration of different funding mechanisms in addition to, but not just a tax credit, to really find the most effective and equitable funding mechanism to expand access to childcare and affordability for the workforce. So that was some context provided that was not reflected in the action plan. Any concerns about adding that to the final report? Okay, great. And maybe I should pause first to say, we went through the whole intro. Any immediate, I'll stop sharing screen for a second here. Any immediate feedback on the first sections so far before we jump into the next subcommittee? Okay. And you can keep thinking while I'll try for 5 minutes to share my screen again. All right. Can you see the licensing and credentialing? Great. So Eli, I'll turn it over to you if you have any context or notes for your subcommittee members that you want to share before we jump into the overview.
Well, first of all, thank you for allowing me to present. It was definitely been an honor to be able to provide whatever insight I had for the group, but more importantly, I think for me, the reciprocal education that I got from all of the subject matter experts in their fields, their level of wisdom, just their understanding of working within a very challenging system that's very daunting, can be very draining at times, and just very difficult to work in. So I always kind of felt like I was a little bit more renewed by hearing their very specific experiences and what they're doing. So broadly speaking, we came up with 4 plans, communicating pathways. Excuse my dog, he's barking in the background. He's pretty riled up right now. But communicating pathways and requirements, really focusing in on entry-level behavioral health positions and supporting more clear pathways to reducing barriers. And and more importantly, supporting people with lived experience. As a person with lived experience, this really kind of resonated with me because I distinctly remember all of the challenges that I had to endure in order to kind of get to the point I am professionally right now. And for some folks at the very entry level position, that can be very difficult for them to have to endure. So we really wanted to highlight that and really support that. But particularly also with the entry level behavioral health positions, really providing people the opportunity who may just like have some interest, but be at a very kind of entry level with very limited access to education or no education at all, and be able to provide them with some experience to like, hey, maybe this is something I want to pursue continually long term. I know we can't do it forever, right? And there is a incoming generation of folks who are just as passionate about the work, but they may not know where to start. And so I'm really hoping that this kind of helps to leverage some opportunity in order to be able to create that for them so that they can know where to start. Once again, it was just very honoring to be able to do that. There was a lot of conversations around like, how do we streamline these processes? But what I appreciated the most was the whole framework was guided by what can make the most impact and have the most feasibility. And I think that framework really kind of grounded us in, because there were so many great ideas that came up, so many discussions that came up that for me, having that framework really kind of helped to synthesize it and really narrow it down. And we didn't just disclude everything either. We still kind of left them there. Maybe those are opportunities that get pursued later. So once again, just a really great opportunity to be able to be a part of that and to see where this goes. And I'm excited to continue to kind of share the message and move it forward as much as we can.
Thank you so much, Eli. Wonderful. So moving to the feedback, most of the council feedback for licensing and credentialing is reflected in the action plan. The one outstanding piece was around exploring strategies to provide free test preparation services and materials to people interested in taking the test. So that was something that wasn't fully reflected in the action plan. So just wanted to open this up for discussion to see if folks have questions or concerns about adding this to the final report.
I do not. And I'm sorry to surprise you with this question or idea, but I'm just wondering if perhaps this wouldn't be the place to potentially add the conversation we were having earlier around telesupervision as a potential thing to look into.
Yes.
And that we could offer that up as an idea for further exploration. And I put it to the group if that would meet the need. Because I like the idea of it showing up in a written document and being support, because it's that would make some sense to me. Because I think that's what we kind of decided is we'll do some further explanation, but I want to make sure that council members feel like that's the direction, like that's the direction that they would support and a good use of people's time.
Thank you, First Lady. See thumbs up. Any concerns about adding that to the licensing and credentialing section of the report, the discussion regarding virtual supervision? See lots of thumbs up. Okay, great. I will make a note of that. Thank you so much. All right. So next, moving right along to education training. So Robin, I'll turn it over to you to give whatever introductory comments you'd like to make.
Thanks, Taylor. And I just want to echo Eli and Julie's gratitude and appreciation, not only to be able to be part of this whole process, but for the amazing subcommittee that I worked with, both all of the folks that volunteered their time. We had a great team from the HEC and then the governor's office. It was a joy to work with everybody, and really it couldn't have gone any better. For the education and training work, we did a lot. Can I just say, I want to acknowledge this subcommittee. Y'all are rock stars. There were 8 plans with 35 unique strategies. One of the things I really appreciate about this report is that everybody on this call has already seen all of the plans. You know the strategies. If we could, Taylor, if we could just take down the slides for 2 seconds, so that if there is any feedback, so there's 2 areas. that we reviewed. And I want to invite people from the subcommittee to jump in and if you've got anything to say. But that first part was sort of the summary, which I thought was really great. And I was appreciative how much we could bring in peers and folks with lived experiences and really lift them up in the work that we did in the committee. And I don't know, Janie, if you wanted to jump in and share anything about that, or also Monica, we talked a lot about how to make sure that community colleges are included in that discussion around education and training. So anything that anybody wants to add to that, just the executive summary for our subcommittee, please go ahead.
Thank you, Robin. I think you covered it well, and I just truly appreciated how the profession of peer support was honored throughout this whole process and included as a profession in its own right, and also part of the continuum of care, and recognizing that lived experience has expertise of its own. And Eli, yes, that kudos on your journey. So thanks, Robin, and just truly an amazing experience to be part of this. So thanks.
I'll jump in and echo what was just shared. And just to say, as somebody with a lot of formal education working as a faculty member, you've made me a champion for peer support specialists. And I am in the public health realm. It's like all I talk about. So I learned, and also to echo what Eli said earlier, I learned so much from the subject matter experts, and I learned so much from within my own committee about that. So super grateful for all of you and Robin for your amazing leadership and to the staff for your amazing facilitation.
And I want to double click on that. My experience with the whole peer support model was to look now statewide at implementing strategic processes that we can lift up the peer support in a more systemic way. Because I always thought it was kind of a YCCO thing because I wasn't aware of what was going on the broader state level. So really, that's such an important population in their own right, but then also to provide avenues for the continuum if they so choose.
Yeah, so much wisdom on the subcommittee. And if there's anybody else that wants to jump in with any feedback for us about that executive summary, you can feel free to jump in now, or like Taylor said, share that at a later time. We appreciate any input for sure. And then the other part, just to get feedback, if there is any, is all of the action plans. And the nice thing about this, like we talked about, you all have had a chance to review it, sign off on it. It just was summarized really nicely by the team. So thank you all for the people that did that work. It sounds like Chad, that was a big chunk of your work. So thank you for that. And so if there's anything that comes up in the action plans that you are concerned about or have feedback on, now's a good time to share it, or again, sharing it over email with Taylor and the team later is totally great as well. Okay, seems like we're in a good place with it. I think the last thing before Taylor, we bring the slides back up and talk about additional recommendations is I just want to call out Shali because she's in the room with us. She was such a big part of how we were able to make the magic happen. So big gratitude to her. All right, Taylor, if you want to talk about the other things that we might want to include.
Great. Okay. Well, I do the high wire active sharing screen. So
you got this.
Here we go. Okay. Hold on one second. Hold on. Thank you, Robin. Great. Okay. And these are the moments where you really appreciate Chad. And this is why he always does this for us. Okay. Folks are able to see my screen?
Yep.
Great. All right. So the pieces of feedback that came up that weren't already incorporated in an action plan for the ed and training as they came forward, there were two. So one is for the culturally specific organization action plan, which was really being specific about providing or exploring ways to educate and train supervisors to support staff in working sustainably with high acuity populations and Mary, I think this was something that you raised during the conversation. So any feedback, making sure I captured this correctly. And then the second piece was around for the action plan on college and career pathways, making sure that the agencies that are implementing, which includes OHA and HEC, should really focus on expanding pathways for psychologists and psychiatric nurse practitioners. So, Clarissa, I recall that being your comment. So just wanted to make sure, not to put people on the spot, but if there's any better way to capture this or anything else that I'm missing, please let me know.
I think it looks great, Taylor. Y'all did a great job.
Great, thank you. So with that, that captures all the feedback that folks provided during the full council meetings as action plans were coming forward. So in the next version that you all see next Tuesday, you'll see these exact blurbs added to the specific section of the report where each action plan is, and it'll reflect that it was from the full council's discussion. All righty, so the last portion is going over the final elements of the report. So you will see, again, in the full document that you have in front of you, there's a section on engagement and feedback. So that really summarizes all of the feedback that you all received throughout this process. So that includes the Behavioral Health Talent Council meetings themselves, where you heard from so many professionals, successful strategies from the First Lady site visit. So there was just tons of field work that came into your meetings that I know you all took with you to subcommittee conversations. So this portion of the report really lists out all of the agendas that you had as a full council during your subcommittee work. There's a section summarizing the culturally specific organization engagement work and feedback that was received. So there's a sort of a summary here and then also a more full appendix that really outlines that feedback and how it crosswalks with your action plans. There's a section on the tribal engagement work that Casey presented on as well. So summarizing the feedback and then a more full appendix as well. And then legislative work group alignment, the presentation that Amy just gave is also summarized in this portion of the report. And then there's a next step section, which talks about the governor's bill and some pieces around making sure we have active data over time around the HEC talent assessment to be able to continuously track our progress. So those are the pieces that are in the final elements of the report. So if folks have any burning feedback on these sections, feel free to share now or over email is also fine. Okay. And if anyone has ideas about how to successfully facilitate review of an almost 100-page report, I'm all ears in the future. It's an endeavor. Okay, so this last slide is on the additional council feedback that I actually just added while you were discussing at the front of the meeting. So these are recommendations that came up during discussions that weren't necessarily tied to an action plan. So Rachel and Clarissa, hearing you talk about specifically the definition of behavioral health workforce, making sure that it's inclusive of professionals that tend to be considered in the medical space and not always included in the definition of the workforce, and then associated incentive programs that may exist for those profession types. So the governor's office would explore legislation or administrative action to align definitions of workforce to ensure that psychologists, psychiatrists, and PMHNPs and other profession types are consistently and accurately referenced as part of the workforce and associated incentive programs. Any feedback there? Not to put you and Rachel, you and Clarissa on the spot.
Just that you act quick. That is amazing because I know
That's
feedback
perfect.
wasn't given timely. And yeah, thank you. I mean, yeah, thank you so much. Clarissa's got her thumbs up.
Yeah, this is incredible based on how quickly this, I mean, you guys are amazing.
Thank you. Any feedback from other council members about adding this to the final report? Questions, concerns, context?
I think it looks
Okay,
great.
hearing. Great. Yeah.
Or are we speak to the first bullet or all the bullets? I'm
Oh,
sorry.
just the first. So
Okay.
moving to the second.
Okay.
And again, feedback on how I captured this would be great. But so I've heard that the governor's office should explore including documentation as countable clinical hours for the workforce. And I think this is connected with the supervision conversation. So welcome feedback on this. Rachel.
I just have a question. Are you all saying that all the work you do in documentation does not count towards your hours of caring for patients? Is that what that says?
That is
Again.
exactly what
Again, you all. Like
happened.
again, like nursing, no way. Like the hour of documentation after seeing the patient. Like, wow. Wow. Okay.
Wow,
However you
it's
need me to help
only a
you in that, I will be a
face-to-face
loud
time.
voice. It's part of learning. Okay.
All right, any concerns with including this recommendation?
Not concerns, but I just wanted to add that this is a huge thing that people talk about, and this will be huge for people if it does go forward. It's constantly like talked about dreadingly in the office when they're working on paperwork that they're like, none of this even counts. So I think that that would be really, really helpful.
Well, and I love it. And I want to jump in here because I do want to add a little bit more context too. This came up a couple of different times, and especially with people who are working with high acuity. And the thinking is also that it provides for better documentation because it's valued, and the documentation is what follows a person as opposed to those interactions. And sometimes the documentation, depending on acuity and severity, is more complicated than the actual interaction. And this is when some of the most skilled work happens. And so we've had in multiple kind of crisis-based settings, this came up as an idea. And, there's more to figure out about how we got here and why. But I thought that was particularly important, just thinking that, when you think about the acuity scale, that the documentation really matters, especially when folks have a low speech output of how, and so that the documentation is really valuable. So just wanted to see where that feedback came from too, came particularly from secure residential. And so I thought that was very meaningful.
I think that's a really good point too. There's sometimes that we spend hours on like one note just talking it through in the office because we know that they get a lot of times during like divorce hearings and child custody cases, they can get subpoenaed and things like that. So just being very mindful, it can really impact a person for sure the rest of their lives.
Mary and then Rachel?
So I did emergency room consultation for 20 years for patients presenting at risk to harm to themselves or others. And really clear documentation and accurate diagnosis determines their follow-up care. So it's more than just paperwork. It really defines care going forward. And to not have our students be able to count that as hours, I've never understood that because it is essential to care. It's not just documentation.
Thank you so much. Rachel?
So I want to add a finer point on the things that I have really learned through this hearing from you all. This whole difference of clinical hours when you're in school, like the nurses do it, and how they're counted, and then the supervision, which are still clinical hours, it's happening after school. So it's like when the schools are regulating it and overseeing it, it's treated one way. And then when it's after school, it's treated another way with this other set of rules and laws and who's making them. So it's very interesting. And I could not imagine it knowing how important, as you've all just said, documentation is. And not to mention right now in billing, a lot of it, you're including how much you reviewed charts, how much you spent on charting. Like that is a newer way of doing stuff. But yeah, it is very interesting that seeing how different the behavioral health system, which of course has medical providers in it, but treats these hours just because it's not done while you're in school. And I'm very much looking forward to celebrating with you all when you get through this.
Thank you so much. Okay, any other comments on the documentation piece before we move to the in-person versus clinical or virtual supervision? Okay, so this was also part of the earlier discussion, but adding this in the final report that the governor's office should explore aligning requirements for in-person versus virtual clinical supervision with the focus on flexibility for culturally specific providers. Okay. Hearing none. First Lady.
I have one question, and it may already be in the report that it's not. The feedback around the integration between substance addiction care and mental health. It came up, it's come, but particularly it came up from the tribal meetings that were the tribal meeting around people are not just treating mental health without addiction care. And there were, I know we've talked about ways to encourage, as a part of the education, ways to encourage or make it clear how one can be dually credentialed or, am I getting?
Yes, and I would turn that to Casey to speak to where that's reflected or if that needs
Is that reflected or does
full
it need to be an
counsel.
additional? That's my question. Thank you.
Yes. Casey, are you able to help us out with that?
I can, but could you repeat the question real quickly?
My question is just making sure the feedback around that mental health and addiction care, that people can be dually credentialed. And this came up this also from a recent field visit of somebody saying, oh, we added an addiction course to our academic choices, and so wondering I can't remember if it's addressed in the report or if it should be an additional encouragement.
So we talked about specifically in the peer space, eliminating sort of barriers to people being able to work with both populations. I don't think that, I think it's probably a longer conversation to kind of determine on the higher up credentials how we can best sort of be able to unite those two fields. But I think that is definitely worth continuing. And I think maybe some of that work in the peer space can help inform that.
Thank you, Casey. Clarissa and then Robin.
I had a question kind of adjacent to this. So I've run into, and I'm just looking for clarification. I'm wondering if it's something that would be added into this bullet point. I've realized that adolescent substance use care is even more separated. Because let's say I'm providing this actually happened to me. I'm providing psychiatric care for youth, for a 16-year-old, and I need them to get substance use care and counseling and, somebody who can provide therapy in that space. And there's nobody who I can send them to because nobody says that they work with adolescents. And I'm like, with the training portion, aren't they getting lifespan? Because like when we're trained, we do lifespan, and then we can get extra, training and credentialing in specifics. But like down here in Southern Oregon, there's that I know of like one major place that's providing adolescent substance use care. And it's kind of like, I don't know where to send them. So I'm wondering if this is adjacent to the bullet point, like if this is even more of a I don't know. I think you all know what I'm talking about.
Yeah, so just to make sure I'm understanding, so I'm hearing that it should be called out as an additional recommendation, like beyond what Casey reflected in the peer specific space, to just say that it's worth further exploring strategies to reduce barriers for dual credentialing with it seems like a focus for youth as part of that. Is that what I'm hearing?
Yeah, like I guess I'm just wondering, like when it's the training, maybe somebody can speak to this when they're trained as KDACs. Is it lifespan? Is it that so it isn't. Okay, so they're getting trained as adult KDAC. So like it's even harder, and we're talking about this, and I'm going to say rural, even though, I'm harping on this like zip code not being rural, but like I just saw a patient from Butte Falls. Anyways, it's harder for me to even find that, so like I don't, yeah, it seems like even more of a difficulty with this bullet point. Sorry,
Yeah.
I'll shut
No,
up.
Monica looks like you have an answer. So I'll turn it to you, Monica, and then go back in line.
Yeah, thank you. So the primary CADC education doesn't specifically call out anything in lifespan or adolescence or adolescence. People can take additional coursework or classes that would give them that information to work with that population, but in those, 6 or 8 classes that they have to take, it is not one of the required educational components for a CADC 1 or 2.
Thanks, Monica. And then we'll go to Robin next, and then Rick, and then Summer.
I'm going to step back because I know that Summer and I'm guessing Van both have comments about this. So so we don't have to swing back and forth, I'll take a pause.
Okay, Rick, you were next in line.
Yeah, and Clarissa, you sort of, it's a whole ball of wax that you just got into. Youth addiction services are not well supported in the state, and you would need to have people. What you don't want is adult services made for little people, which has been tried, which was the model that the state used in the 80s. And so you really need people who are really working with trauma, with family therapy, with whole systems care. They're very deep into the pool kids. And I've often advocated that the whole youth system for services should look more like the co-occurring youth services and mental health, because the kids are coming in not as SUD, but really as a cluster of problems, and SUD is one of them. So lots of trauma, and it should be specialized, and should be probably more specialized than it is. And then you need a working model, business model that supports that doesn't exist in the state.
Thank you, Rick. And we'll go Summer and Van, and then we're close to wrapping up presentation and closing. So I'll go to you, Summer.
Okay, I'll talk fast. So first, you can refer them to us if they're outpatient only, we will see them. But really, what you have to, I completely agree with Rick. The CADC prep is not sufficient to really ethically treat a lot of the issues that we see with our kids. The more logical add-on is helping support mental health counselors in gaining interest in being able to add on SUD, since they already have the training and competence typically to work with youth and families, and that's really what's needed. The other barrier with our CADC staff, even when we have people who are quite skilled, they can't pass the background check to work with kids a lot of times because they have a lot of their own lived experience, and so that's another barrier. Where adding on to the mental health folks makes a lot of sense and would probably gain more traction.
Thank you. Very helpful. Van, Robin, and then I'll share a screen on the adapted recommendation for review.
Yeah, so I was just going to say, so we are coming out with an adolescent treatment endorsement. So it'll be an endorsement that tacks on to a CADC. It'll be a course, should be 12 hours, and it'll have a psychometric exam as well. And endorsements, or we were calling them micro-credentials in the subcommittees, is something that we're starting to launch. So we have a forensic peer endorsement. We would like to do a co-occurring and also a clinical supervisor that coincides with the OARs. But yes, we are doing an adolescent treatment endorsement because, all y'all's points are very valid. And we've got a psychometric exam that's being developed, and it should be out pretty soon. So, hopefully it's a way to, we kind of look at the endorsements as a way for employers to, help screen potential employees as well, because if people go out and get endorsements in a specific topic, then it just helps say this person is knowledgeable in this particular area. And then as far as the registry entry, it's just a stamp right on the person's credential. It expires with their credential and so on. So we are addressing it.
Thank you so much, Robin and Shira.
Yeah, my last thing I just want to flag for you, Taylor, is that third bullet, it talks about aligning in-person supervision with remote. And I don't think aligning is quite the right word because there's different rules for in-person um, versus remote. And so I don't know if reimagining is not the right word either, but it's something, they shouldn't exactly align. I think they need to be repositioned so that they can be used like more, like the either could apply. Do you know what I'm saying?
Yes, I can definitely
Okay.
clarify that for the final version.
Great.
Thank you, Robin. Shira.
Thanks. I just wanted to add, and maybe this has already been captured elsewhere, but in addition to like the training and credentialing process for co-occurring folks, the enhanced rate that's available to organizations who are already providing co-occurring care is only available to organizations who have gone through the very burdensome co-occurring certification process through OHA. So there's organizations like mine that have plenty of clinicians that are dually credentialed, and we're providing whole person care. We're providing mental health and substance use disorder treatment from the same provider. But there's no enhanced rate that we can bill for those services because I don't have capacity to go through a whole additional certification process through OHA to be a certified co-occurring provider. So I think that it would be worth looking into that additional layer that prevents organizations from being reimbursed appropriately for the care that we're offering.
Okay. So I will summarize what feedback I've heard for this particular recommendation, ask for any other comments, and then move us forward to the last slide. But that it would be the governor's office exploring strategies to reduce barriers to being dual credentialed for both individual providers as well as organizations that are seeking that dual credentialing as an organization, and the rate associated with it, with a focus on youth providers and helping connect existing youth mental health providers to also receive a said credential. So this is worded poorly, but does that generally capture the conversation? Anything else folks would add before we move forward? Okay, then we will reword this and can include it in the final report that you will receive next week. So with no other comments on that portion, we'll just move to the last two slides and turn it back to you, First Lady. The final piece of the report are beautiful appendices. So feel free to take a look at those. Another asterisk on the bios, please take a look at your bios and make sure you are good, don't have feedback on those. And then the last slide is around changes that you will see primarily technical between the version that you received Tuesday and the final, so that you all know and don't feel like you need to duplicate this in your feedback should you email it, but we will go through final copy editing. The appendice structures will be aligned. We'll add the council feedback on the action plans that was just discussed today. The links to the final action plans will be included. We'll have a long list of all those action plans. Then we are going to add a new appendix on just the prioritization process that the subcommittees went through to really show where all of the HEC talent assessment recommendations landed through this process, some of which were discussed but not necessarily folded into a plan. And then finally, any of the additional feedback that came up today. So these are the plan changes you will see. You will get an updated copy on Tuesday before the final meeting, and that will be the meeting to consider fully adopting and sending it along to the governor. So with that, I will turn it back over to you, First Lady.
Okay, we did it. Okay, thank you so much, everyone. So our final meeting is going to be January 9th from 2 to 4, where we'll finalize the process. And I want to a couple things, and we'll finalize the report as well as we're going to talk about next steps and what happens next. We are excited about upcoming opportunities to advocate and to work together in the future, and so we will be reaching out via email, and we'll be finalizing some of these things. It is important, as per other councils, the governor will look at recommendations and then make some decisions about what to implement. And it's really important to all of us that you get that feedback. And so thinking through reconvening folks in March to look at other ways in which the things that have been taken up and how that might go, because you've done great work and you deserve to know the next steps, as well as we said, there's opportunities to advocate coming up in the short session around a small bite of our work that was able to move forward in February. And so look forward for that. And then we'll look for an opportunity for us to gather together and celebrate all of the hard work of y'all and staff. And then I think with that, I think that's all I have. Again, so grateful for all of your attention and time. I know you have really busy lives and jobs, and that you have stayed through this is really significant. And then get back your bios. And as we think about getting closer to the final report, we obviously have ideas about governor and legislators and other people who will be interested. And if there are people that you think should be particularly deserted to, let the office know. I'm sure there are people in your networks, because I think it's really meaningful when people see the recommendations, that they see that filters up, and that's been captured, and that their voices are being heard. And so if there are other organizations that you think would like to see that, I know when I do field visits and I talk about the work that you're doing, frontline providers are really relieved that people are continuing to try to make this work better, and it creates just that alone helps with retention, because people know that we're interested in making this work that you can do for a long time. So with that, again, thank you, and look forward to seeing you for our final meeting. Hopefully not our final interaction, but our final meeting on January 29th.